Welcome to Parallax by Ankur Kalra, a podcast produced by Radcliffe Cardiology to bring you a new angle of all things cardiology and the best from the US Cardiology Review. Published every second Monday, Ankur Kalra, MD, interventional cardiologist at the Cleveland Clinic in Ohio, USA, speaks with legendary cardiologists, reviews late-breaking trials, and interviews authors of our latest and best US Cardiology Review articles. We call them #audio articles. Parallax is the effect whereby the position or direction of an object appears to differ when viewed from different positions. So this podcast is your fix of reliable updates on all things cardiology by someone from a non-traditional background who is always looking at the industry from a new angle. Now, here's your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. As I've been introducing these episodes lately, these are all incredibly hard and unprecedented times for all of us. And, the hope is that all of us are going to get through this safely, and we're going to learn a tremendous amount of how to operate in a world post-COVID-19. With that introduction, I have the true honor and privilege of having on the show a person I call my brother, my friend, my buddy, my partner in crime, what have you. But I have on the show today Dr. Grant Reed. Dr. Reed is an interventional cardiologist at the Cleveland Clinic. He is the director of the STEMI program at the Cleveland Clinic, and he has a focus on coronary and structural heart interventions. So when news started breaking out from Seattle and New York, and when our state, the state of Ohio, started taking action, we all reached out to Grant, asking him about how to handle cardiovascular emergencies in the cardiac catheterization laboratory. And I think he's done a great deal of reading and research, and has put out the commandments, if you will, for all of us to follow. So with that introduction, Grant, welcome on the show.
Hey, thank you so much for having me, Ankur. And, that's probably the kindest introduction I've ever had. I think there's really no greater honor to be called someone's brother. So I consider you the same. It's just an honor to be here. And, thanks a lot for having me today.
Yeah, no, thanks for the time. So, Grant, I think I'm going to start the show by asking you, when you started hearing about COVID-19 in the news and all the developments that were occurring, and there was, I think our state was arguably the very first state in the entire country to start social distancing measures. Did you think that this was going to change the way it has now, that we know, the way it has now changed our practice?
Yeah. It's looking back at it on, how things have changed really just over the last month and a half. It's really been pretty dramatic. It doesn't seem like it's only been about 6 weeks since we've started down this path, but we're already thinking about things in life in terms of what it was like pre-COVID. It seems like it's been so long, and it's only been a month and a half, 6 weeks roughly, since Ohio issued the closure of schools and stay at home and so on. I mean, I think my expectations early on were that this was going to be a pretty significant event in the history of American healthcare. Just seeing everything that Europe had been through and reading about China's experience, I knew this had the potential to get very serious very quickly. And in and around our institution at Cleveland Clinic main campus, and I'm sure you can attest to at Akron General, we started developing plans very very quickly. I think what's been really impressive is the speed at which we've been able to put things in action. Our administration has been very proactive, and I think has had the foresight to I think, anticipate where the governor was heading in terms of reducing and really eliminating non-essential or elective procedures. So we were on board with that from the very beginning, and we were able to ramp down very quickly. And that actually was a challenging thing to do because especially in cardiovascular medicine, so much of what we do and provide are life saving or really quality of life improving measures. And delaying these things is tough. It's tough for patients, and it's hard emotionally on patients as well as on us, because we were connected to our patients. We want to offer them care. And I think at first, one of the hardest things for me was having to call patients and tell them that their procedures were delayed. I had a few patients that really did not take the news very well. And I think, when the governor came out and said, this is something which is, a policy for the state of Ohio, it gave us something to fall back on. But a lot of, patients were reluctant to kind of go along with that at first. Now I think it's a little easier because people understand the gravity of the situation. So things have really evolved, and, as we all know, things lag back behind by a few weeks. So I think now we're finally settled into kind of the new reality of, elective procedures being deferred. And I think hopefully we'll get to a point that we can ramp up again pretty soon. But that I think was the biggest thing. Early on, I anticipated that it would be like this. It's just when you experience it and, your whole routine has changed at work. I think living it is a whole nother thing. I think we've just been fortunate at the clinic to be in a very supportive environment that has been really, very, very, very supportive of all caregivers, not just physicians, but everyone else, and kind of have this we're all in it together mentality. You hear and you read about a lot of situations around the nation where other providers haven't been quite as fortunate. So, I think we anticipated, but now that we're in the thick of it, obviously we're not encountering the same volume of COVID patients as other places, but it's still somewhat, it's a very different experience. It's kind of surreal to be living through this.
Yes, I would like to take this opportunity to give a shout out to the Cleveland Clinic in how well they have taken care of us as healthcare workers. Our structural heart, one of the team members of the structural heart team at Akron, you're a member of this team as well. One of the members had to be quarantined for testing positive, and what we learned was that healthcare worker and the family of that specific healthcare worker were supported incredibly well through the Cleveland Clinic system. As in, meals were being provided at their home, and every measure was taken to make sure that they're comfortable, which I think has been incredible. I mean, we've gotten thank you cards. We've also gotten just yesterday I saw a placard installed at my neighbor, who also happens to be a Cleveland Clinic employee, installed outside the house saying that we're heroes. So it's sort of humbling, and it's the recognition is very heartwarming. And you're right. I mean, we've been fortunate to be very well supported by our leadership at the Heart, Vascular, and Thoracic Institute, but also the institution overall. So let me ask you this. So like you said, a lot of what we do is very essential. So I think cardiovascular emergencies and non-essential don't go together. And a lot of what we also do is, can't be delayed. How, as the director of the STEMI program, and obviously STEMIs don't fall under the rubric of non-essential anyways, but thinking out loud about triaging non-ST elevation MI cases, for selective invasive strategy versus early invasive strategy, what were the discussions that happened for you to be able to put that algorithm together?
Yeah. I think there are, as you said, I think the two different categories in which we've been classifying patients, and that's into the cardiovascular emergencies, those being ST segment elevation MI, as well as STEMI, which are high risk, patients that really can't wait for catheterization, who need an immediate invasive strategy, and then patients that have acute coronary syndrome, which are maybe not quite as urgent, low risk STEMI, unstable angina, and stable angina. And just kind of looking at, kind of all these patients with coronary disease into, kind of as a group. Early on, we, as is the case with everywhere around the nation, it was evident that we were going to have to effectively triage patients in a way that was responsible, which allowed them to get necessary health care in an expedited fashion if needed, but also minimize the risk to providers. So when you think about STEMI, and one of the roles I have at the Cleveland Clinic is I'm fortunate to be in charge of our enterprise STEMI program, which actually encompasses Cleveland Clinic main hospital as well as all the regional hospitals, and gives recommendations to our affiliate hospitals as well. It was evident that as this COVID pandemic started to unfold, that we were going to have to make some pretty significant changes to our status quo, to how we provide STEMI, not just to COVID positive patients, but to all patients, so that we can minimize the risk to providers. So, and I can kind of lump high risk and STEMI into this group because these are patients that maybe are coming in, kind of urgently, that don't have ST segment elevation, but maybe they have refractory chest pain, or they're unstable, don't meet quite STEMI criteria. But bottom line, these are acute or emergent catheterizations. And I think number one is we need to all understand that, and I think we all do, have a great sense of duty to the patients, and know that, and at least my attitude and the attitude of our entire section has been that we want to take care of patients, number one, and that although the COVID pandemic is affecting all of us, it really shouldn't impede the high quality care that we provide every day. And there are certain tenets that I think are very important for us to appreciate. And I think that's that we want to provide the same high quality care of patients regardless of if they have COVID infection. We want to preserve the emphasis on primary PCI, which I think is evidence-based and been proven to be the most effective treatment for STEMI, rather than fibrinolysis or other strategies. And we want to do this in a way that minimizes the risk to providers. So early on, myself and other individuals in my section and our chairman, we're all very heavily involved in conversation about how we can change the Cleveland Clinic STEMI policy so that we can minimize the risk to providers and also to patients in this process. And there were a few things that we adopted very quickly. And this is based on our conversations, but also based on the ACC Interventional Council recommendation, SCI recommendations of other professional groups, and seeing what had been going on in Italy and Spain. And what we did is and I think this is probably similar to a lot of other institutions, but we created a policy that the patients that were either COVID positive or very suspicious for COVID, that providers should wear N95 mask and other standard precautions, including eye protection and droplet precautions. So that was at first in patients who are COVID positive or high risk, and we've since liberalized that to anyone who's uncertain of their COVID exposure that may have an exposure in the community, because obviously, the way that we were screening for COVID and testing for COVID at first was a lot more restricted. Now it's gotten a little bit broader. And this is actually how we treat the essential procedures, which we're doing, is that we'll, it's highly recommended. And in every case, to my knowledge at this point, we are testing patients for COVID prior to them coming in for their surgery, for TAVR, and even for their PCI. So we treat the same for STEMI, although we don't recommend patients get tested in the emergency room. We recommend that they're screened. So we've eliminated all the ED bypass STEMI. We actually don't recommend patients come right from the emergency room. I'm sorry, right from EMS to the cath lab, which is an avenue which we used to bring patients in. EMS can activate based on the EKG. We don't allow that anymore. We send all patients to the ED first, and then that way they can get quickly screened for COVID in terms of their symptoms. Fevers, chills, other symptoms. Anyone with contacts, and if it's evident that they're having a STEMI and they don't have these high risk features for COVID, then we treat it as if it's just a typical STEMI case, and everyone wears the standard precautions. However, if there's any concern for COVID, then we take the extra precaution of having everybody, not just the providers, doing the case, not just the in our case, the interventionalists and the fellows, but also all the nurses involved in the techs wear the appropriate precautions. And, that in our experience has not slowed down the ability to provide timely STEMI care. If anything, it gives everyone that much more assurance and confidence that we're doing the right thing and taking the right precautions. Now, it does, rely on the administration supporting this and having enough PPE in the cath lab. But we're finding that we're not having to do this for many people. Our STEMI case volume is a reasonable volume for a large hospital system, but we're able to handle this. And I think it's allowed, providers and caregivers to be that much more confident that they're protected during the case. And I personally had a case a couple of weeks ago where it was a 30-year-old gentleman came in with anterior ST segment elevations on their EKG, and I had a suspicion it wasn't a true STEMI, but in the context of their EKG, we had to do the case. There was no way that we shouldn't do the case. Very high risk for COVID exposure. Ended up having a viral myocarditis and being very sick. And the whole time we all wear N95 masks. He was in the cath lab twice that day for different reasons. And none of them were coronary related. So everyone was careful, and we I think all felt good about the care we provided. But that's number one, is we want to make sure that providers are feeling safe. And I think taking a couple extra precautions early on, you can do that in a timely fashion.
Yes, no, thanks a lot for going over the protocol and, the thought process. I agree with you. I think primary percutaneous coronary intervention is evidence-based, is safe, and is effective, compared with fibrinolysis. And just to expose our patients to the attendant risks of fibrinolysis, particularly with regard to bleeding, and rescue percutaneous coronary intervention, were risks that as a group, like you eloquently discussed, we didn't feel it was worth the risk that our patients should be exposed to. And, we've maintained the primary PCI program. How has this affected the structural heart interventions? The COVID pandemic has it definitely forced us to reprioritize a lot of what we do in general. And when it comes to TAVR, I think we're in a unique position where we're a referral center of last resort. And a lot of times, we have a very high volume of TAVR and other structural heart disease referrals on a monthly basis. And a lot of these patients are relatively medically complicated or complex, I should say. They have multiple issues. They've either been assessed by a local facility and then referred here. And many of them are just in our community as well. But we actually, many of the patients that we encounter, at least with severe aortic stenosis, they're pretty significantly symptomatic. So within our structural heart disease program, we have a team of incredible nurse practitioner coordinators, nurse specialist coordinators as well, that help us to triage patients. And patients that maybe were asymptomatic with severe aortic stenosis, patients that, or just I should say mildly symptomatic, because we don't typically, even encounter patients that are truly asymptomatic
outside of the context of a clinical trial like early TAVR. The bottom line is that if patients had very mild symptoms, who were doing okay, then those patients are more able to be deferred until after these restrictions from the governor are lifted. In reality, many patients don't want to wait, right? And the more that you talk to patients about their symptoms with aortic stenosis, it seems like the more symptomatic they become. And I don't know if that's the cognitive aspect and the psychological aspect of having severe aortic stenosis, but I find that the more that you talk to patients and you explain their issue to them, it almost seems like the more symptomatic they become. And in our practice, we actually, we certainly have reprioritized certain patients to be done a little bit earlier and certain patients to be done a little later. But we've actually, still kept up with volume fairly reasonably during this time, just because of the nature of how sick the patients are that we treat. Another question I get asked is, are we doing more bridging aortic and balloon aortic valvuloplasties? And that's something which not a lot of centers do in high volume, but at the Cleveland Clinic, we actually do a reasonable amount of, because we find it to be both a useful diagnostic and therapeutic tool in patients that you need to bridge the TAVR. And we at least were concerned that, we're not going to have the operating room time or the ability to offer TAVR in an expeditious way to inpatients that are admitted. So we're going to be doing more BAVs. And in actuality, we have not had to do that at all. And if anything, because we've had some patients cancel their TAVR procedures just out of their own volition because they don't feel that it's safe to come to the hospital for one reason or another, then we'll have a couple, spots open. We've been able to adjust inpatients that have severe aortic stenosis with TAVR a little bit more readily. So, I think that on balance, it seems like our structural division is handling this pretty well. But, it's a week by week process. We're constantly having to reevaluate things. And, I think what we're experiencing now in terms of our volumes is a reflection of, cases that were scheduled a few weeks ago. And as we all know, the changes that are made from the public health standpoint affect patients being infected, today and tomorrow and in the immediate future, but that their consequences of their infection aren't evident for, 10 days, 2 weeks sometimes. So it's the same kind of thing we're seeing in our volumes, is that, I think our volumes are down now because of the changes that were made a few weeks ago. And when we expect to ramp things up again, there's some inertia to this, that it's going to take a little time to ramp back up again. And also for patients to fully buy in to being in a healthcare facility, and at least the perception that they may be exposed to infection. So I think that is something which we go to great lengths to assure patients that, yes, you're perfectly safe here in the hospital because we're taking so many precautions. And if anything, this environment is probably all the more safer than it is in the community if you were to be, even out at the grocery store per se. But I think at least that's what we've experienced, is that our volumes are down to some degree, but we're still providing good care. And I think that's the important thing. And I think it'll probably nationally probably not rebound immediately. I'm not sure what you think of that, Ankur, but that's my perception.
Yes, I think it's going to be important how we reinstitute our operations, and that's something I wanted to discuss with you. I think there's, for the first step, again, just to reiterate the importance that in cardiovascular medicine, particularly interventional cardiology, there are very few procedures which are not essential, like you said. And, I was just reading the statistic which was sent out in an email by the American Medical Association that in the months of March and April combined, there have been in excess of 15,000 deaths compared with what that number looked like last year about the same time. And these are non-coronavirus deaths. These are deaths which, are just the 15,000 excess deaths. And, I think at some point, I'm sure there's going to be analysis done, but the collateral damage with regard to patients either being too fearful of seeking emergency care or prolonging access to care because of coronavirus and social distancing and physical distancing, I'm sure there's going to be collateral damage, which analyses will come out. So I do think it's very important to reinstitute care responsibly and keeping the public health interest in mind, of course. How do you foresee that getting operationalized? Like, how do you foresee that getting instituted?
That's a great question. I'm completely with you that we need to find a way to do this in a responsible fashion. I think number one is that it's going to have to be not a trial and error, but that we're going to have to be able to react to the changes that we see quickly with data, and be able to, if we open things up again, be able to pull back rapidly if we notice over the course of the next few weeks that we're noticing an increased risk of infection or prevalence of infection in the community. So I think it's going to have to be done with a lot of attention to detail when it comes to data and monitoring, with testing, and then the ability to make rapid changes. And that's actually one of the things I've been very impressed with at the Cleveland Clinic. And not to necessarily tout all the great things about our organization, but one of the things that has been very impressive to me is just how rapidly we were able to make change and how responsive the leadership was to the recommendations that we have. So I think being able to do the same thing in the community, being able to react to the data that we see and say, hey, we're spiking, we need to pull back quickly. I think that's the key to being able to open up again. So operationalizing that at the clinic, I think will hopefully, and we'll be able to react the same way. We're being able to look at data in terms of the number of admissions that we have, our resource utilization, our ability to handle the needs of our community, and then be able to adjust from there. And I think, at least my perception is that nationally we've gotten a lot better at that over the last several weeks. And that's one of the keys to being able to handle a high level of infection in the community, and is not necessarily to socially isolate forever in every way, but to relax restrictions in certain ways, and then to be able to shift resources in a way to handle the areas that are spiking the most. So operationalizing, I think, is going to be driven by data. It's going to be also something which I can see, especially if there's kind of framing it in a way that there may be more than one wave of this. We're going to have to react to that in a real-time fashion. As we know, is nationally a 38% decrease in cath lab activations from March 1st to early April, I believe, and in Italy, 70% reduction in STEMI volume in the Lombardy region. In Spain, 40% reduction in PCI for STEMI. I'm hoping that as patients start to re-engage with healthcare, maybe we'll see these numbers go up, because there's a not that we want more patients to have STEMI, but as we all know, these patients are out there, and as you mentioned, there's going to be a lot of indirect consequence of what of the COVID infection. I'm not really sure what the reason for those mortalities are, but I at least suspect that a number of them are missed STEMIs, are patients with stroke, are patients who are maybe otherwise maybe they would have avoidable mortalities. So that, I think, is going to be one of the more interesting analyses that comes out of this is not just what the effect of the COVID is on the patients who get it, but also what the effect of this is on society as a whole. We all understand, at least, and we're much more familiar with the economic effects of this, but what are going to be the effects of public health that are maybe more indirect? That's a great question. I think it's going to be tough to analyze, but I think we're starting to get a sense that this is going to affect a lot more than just the people who have the infection.
Yes, well, Grant, I know you have a clinic schedule ahead of you, but thank you for making the time to talk to us. Thanks for all that you've done to educate us and lead us and provide guidelines for appropriate evidence-based care, even in the midst of a pandemic. It's been great to get to know you over the past year, and have an opportunity to work together doing cases, write papers together. And I'm gonna put a shameless plug for our paper that we've written on just the operationalization of the cardiovascular service line during a pandemic, which is currently under review. But it's been a great collaboration with you, and to get to know you, and I just can't wait for the camaraderie and the brotherhood to keep growing.
Yeah, I can't thank you enough for having me, Ankur. For those of you who don't know, Ankur and I, we did some structural cases, some TAVR down in Akron General, and now they have a program going with him and with Anmar Kanan and Joe Lahora. It's a great thing going, and I couldn't be prouder of you guys. I think you guys are doing a great job, and I think one of the best things about being here is has been working with you and others, being able to not only provide high volume, good clinical care, but be able to do these important academic things. And I'm really excited for some of the things that we have coming up, and a lot of it coincides really well with what we're talking about today. So, I think stay tuned, and I think only good things are going to come.
Well, thanks again, Grant. Thanks for the shout out, and thanks again for our time. It's been incredible to have you, and we'll probably have you back on the show again.
Awesome. Thanks a lot.
Yeah. Bye-bye.
Dear cardiologists, we want to make this podcast about you and for you. So please email us your critical thoughts, comments and questions at podcast@radcliffe-group.com and visit uscjournal.com for more information. You can also follow us on Twitter, LinkedIn, Facebook and Instagram at Radcliffe Cardiology for daily updates. Join thousands of cardiologists and become a Radcliffean by registering to radcliffecardiology.com. You will receive regular newsletters and gain access to hundreds of expert interviews, educational webinars, clinical cases, and peer-reviewed articles from our 6 medical review journals on general cardiology, interventional cardiology, arrhythmia and electrophysiology, cardiac failure, and vascular and endovascular surgery. Thank you.